social media's #1 platform for spine health education and surgery. Join with us now.
All right. Good afternoon, everybody. Welcome. ADR, Artificial Disc Replacement Spine Surgery Education Group on Facebook, the largest and most educational group we have today. Remember, if you like this video, we're going to have a lot more. So remember to subscribe. I've got a familiar face you all may know, Dr. Sonal Sodha. How are you doing today?
I'm good. How are you?
Good. So what we're going to cover today is pre-surgery questions. We're going to kind of knock all of them out. That way you can exactly figure out what you need to prepare for prior to surgery. So we're going to get started right away. We're going to make it real quick. Let's talk about pain medications. My back is hurting. I'm prescribed some narcotics or things like that. And let's even talk about aspirin, Tylenol, Advil, what is allowed and what is not allowed prior to surgery.
Yeah. Okay. So this is a really common question. The most spine patients are on kind of a certain cocktail of medications before surgery that they've sort of tried to manage their pain or their leg symptoms or their arm symptoms. A lot of them are on Tylenol. A lot of them are on a muscle relaxer like Flexeril or Robaxin. A lot are on gabapentin, and some are on narcotics. In terms of what needs to be stopped and what doesn't need to be stopped, you can continue to take Tylenol. You can continue to take the muscle relaxers. You can continue to take gabapentin. When it comes to the class of NSAIDs, that's Advil, ibuprofen, Motrin, Aleve, that class, some of it depends on whether you're having a fusion surgery or not. And some of it depends on surgeon preferences. So the data, some articles have suggested that that class of NSAIDs could slow down fusion. Some publications have said it doesn't. And so it's kind of been a little bit back and forth. You'll want to ask your surgeon what their belief is, because usually they'll have guidelines or from their own training or their own anecdotal experience. They'll either want you to stop it or they'll think it might be okay to take up until surgery. So just clarify that one with your surgeon. And then lastly, some patients are on narcotics before surgery. Ideally, if you're able to come off of narcotics before surgery, that would be great because it'll help us manage your post-surgical pain better. It'll give us more tools to work with after surgery. If you're taking high doses of narcotics before surgery, it just kind of ties our hands a little bit after surgery in what we can use and what doses we can use to manage your pain after. So as best as you can, if you're able to come off the narcotics, it'll just make your post-surgical course probably a little bit smoother. And then the other things to talk to your doctor about are the blood thinners. Some patients are on blood thinners for cardiac reasons, or they've had previous blood clots. And so talk to your primary care or your cardiologist, whoever is prescribing the blood thinners, about when it would be safe for you to stop before surgery, and talk to your surgeon about when they want you to stop. Sometimes it's 3 days before surgery, sometimes it's 5, sometimes it's 7. So just talk to them and make sure you're clear on the guidelines. The reason that we have you stop blood thinners before surgery is because if you take blood thinners up until the day of surgery, that makes your blood a little bit thinner. And so you're a little bit oozier during the surgery. It puts you at a higher risk of developing a collection of blood, a hematoma, whether it's in your neck or in your low back. And then sometimes the hematomas can compress nerves after surgery. Or it can lead to drainage from your wound, which leads to wound healing issues and infections, et cetera. So that's the reason we're a little bit cautious when it comes to blood thinners.
And what, as far as narcotics, 1 week, 2 weeks, what would be the most prime?
Yeah, the sooner the better, I think, is a good guideline. And of course, a lot of it depends on the patient, on how much pain they're in, on how long they've been taking them. And so sometimes it's really hard to stop cold turkey, a month or two before surgery. I think the best guideline is, just the sooner the better and do the best that you can.
And then what about like some of the supplements, turmeric, fish oil? Mm-hmm. I know those are no-nos prior to surgery.
Yeah, I think, the main ones that come up are the fish oil and vitamin E. Those are the two main ones because some studies have shown that the omega-3 fatty acids can lead to more bleeding. And so usually surgeons have you hold it a couple weeks before surgery and then a few months after surgery.
And then what should I focus on diet-wise before coming in? Obviously, I want to make sure that I'm getting a lot of fiber intake, because obviously the higher dose of narcotics is going to stop things, constipate you. What are your recommendations as far as diet is concerned prior to surgery as well?
Yeah, good question. And sort of along those lines, a lot of patients now are on these weight loss medications, Ozempic, Wegovy, Mounjaro, the class of GLP-1 agonists. And so the important thing to know about stopping those before surgery is you have to stop them 7 days before surgery. And the anesthesia, that comes from the anesthesia guidelines, the American Society of Anesthesiologists. They've been really strict recently about this 7-day policy. Because it increases your risk of aspirating or of a pulmonary aspiration. So stomach contents, gastric contents going into your lungs when you're under general anesthesia. And so I had a patient recently, she stopped at 6 days before surgery and not 7. And the anesthesiologist did not feel comfortable proceeding with surgery. And so just be really mindful of when that last dose you take of the Ozempic, Wegovy is. And then to get back to your question about the diet, honestly, I wouldn't make drastic major changes before surgery. I would just try to keep it as well balanced as you can. Some protein, some veggies, some carbs. I would not do anything dramatic, no major weight loss diets before surgery. Just don't rock the boat too much. The key thing is if you're a diabetic, just work on tight glucose control. We like our patients to have hemoglobin A1Cs, which is the marker of kind of long-term glucose management. We like it ideally to be around 7 or below 7. And so if you are a diabetic, just work on really, really tight glucose control leading up to the surgery, because it'll help with wound healing. It'll help minimize your risk of infections. It'll help you fuse if you're having a fusion surgery.
Fabulous answer. I learned a whole lot with that one. So I appreciate that. So I just got steroid injections a month ago, for example. What's the timeline on those? Because obviously that's something you see a lot as well, right?
Yeah. And we get that question a lot too. The general guideline with steroid injections is to not have a steroid injection within 3 months of surgery. That's actually not just for spine. That goes for most of orthopedics, like hip replacements, knee replacements. Those steroid injections can increase your risk of an infection. So we generally give it 3 months to kind of clear out of your system so that it doesn't pose that risk when you're having surgery. So when I'm scheduling patients for surgery, I always ask when their most recent injection was, and I always make sure we schedule them 3 months or more out from that.
Okay, perfect answer once again. So then, any alerts that I should be telling the surgeon prior to it? And this can cover a wide range. And, one of the best things I've seen in surgery is the most honest patient. You need to tell them everything, whether you did some drugs or whether you did some narcotics and the whole gamut of things. And then maybe you ate something you felt that wasn't proper. I mean, what are some of the biggest alerts that you think they should ask?
Yeah, that's a great question. I think, three main things come to mind. Number one is if you have an infection, and that is an infection of any kind, whether you have pink eye, whether you have a respiratory tract infection, whether you have a urinary tract infection, whether you have a wound anywhere on your body or an ulcer that's infected, any infection of any kind, you should let your surgeon know. Call your surgeon's office before surgery, give them a heads up, say, hey, I've noticed I've had this infection. Does this affect anything? A lot of times it will. A lot of times a surgeon won't want to put your body through a surgery and more stress if it's already under stress and fighting an infection. So a lot of surgeons will wait until you've cleared it. The other thing is if you're having a surgery with hardware, so whether it's a disc replacement or a fusion, it's generally not recommended to introduce hardware in the setting of an infection, of an ongoing infection that your body is trying to treat or clear. There might be some wiggle room when it's just a decompression, just a soft tissue procedure, but if there's hardware involved, vast majority of surgeons will postpone the surgery if you have an infection. So that's number one. Number two, if you have any skin issues, that's anywhere in the zip code of where your incision might be. So if you have a rash or an allergy or eczema or psoriasis or anything like that, that is on the front of your neck or is on your low back or anywhere near where your surgical incision is, then let us know in advance. Because sometimes we see it in pre-op on the day of surgery and we're like, wait a minute, when did you get this burn? Or when did you get XYZ? And then we have to cancel and postpone surgery because we don't want to take the risk of making an incision through skin that's not healthy and then having you suffer through trying to heal, a really challenging wound to heal, or, get you an infection. And then the third thing I would tell your surgeon about is smoking. So most surgeons prefer that you stop smoking usually about 2-3 months before surgery. A lot of them test for the nicotine in blood before surgery, and this applies most to fusion surgeries because that nicotine, it's going to slow down fusion, it's going to increase wound healing issues, infection issues. And so if your surgeon asks you to stop smoking before surgery, and if you just haven't been able to, then you should let your surgeon know. Give them a heads up in advance, like, hey, I'm down from a pack a day to half a pack a day. I'm not quite there yet. And then they can adjust the surgery date accordingly, but just let them know.
What about like snuff and nicotine gum, and will those all kind of fall in the same category?
Yeah, so it's not just the smoking, it's actually nicotine in any way, shape, or form. It's the nicotine. So whether it's gum, whether it's patches, cigarettes, that's a good question. It's the nicotine.
Perfect. Thank you so much. I think this has been great. I think it's a great way for people to start before they come into surgery, and I think it's very educational. This has been really fantastic. Dr. Sodha, I really appreciate your time today.
Of course. The only other thing I can mention that comes up a lot in our preoperative visits is patients asking, should I exercise? Should I do physical therapy? What kind of physical activity should I do? And, the general guideline I give is just to stay active and just keep walking. Walking is kind of the most universal thing. Just walk as much as you can. You don't have to hit the gym. You don't have to try to do any strength training, weight training, anything like that. Just stay active. If you're in PT and you think it's helpful, sure. There's nothing wrong with a little bit of what we call prehab, building some core strength before, building a little stamina before. There's nothing wrong with that. But you don't need to dramatically alter your workout regimen because you have an upcoming surgery.
I have one more question. What about, a few days before surgery, I got to come in for blood work and some other things. Describe really the things that you're looking for. And that way, maybe that can prevent problems arising during surgery for it doesn't get canceled as well.
You mean what the markers are in the blood work?
Yeah. Like what are you looking for to prohibit things or make sure things are all aligned and ready to go?
Yeah. So generally, it's the basic panel of CBC, complete blood count, BMP basic metabolic panel, coags, so how your blood is clotting, and then we honestly we actually leave it to the primary care doctor for the most part to quote medically clear you for surgery, and so they review the labs and they send them to us, and then if they see any red flags, they further work it up and get follow-up labs. And then if there's anything off, they generally run it by the surgeon's office and say, hey, are you okay that their hemoglobin A1C is 7.2 instead of 7, or something like that. But we do, it's a lot of the shared decision making with the primary care doctors and the internal medicine doctors when it comes to labs, EKGs, chest X-rays, things like that.
Great answer. I learned a lot today myself. And as I said earlier, I really appreciate your time and the effort. The group really thanks you. And hopefully we get a lot taken care of with this. Thanks so much.
Thank you. Thanks, Jamie. Thank you. Good to see you.